Good morning or good afternoon or good evening to everybody, dear colleagues. My name is Giacomo Bellan from the University of Milan Bicocca in Monza, Italy, and it's my pleasure to be able and share with you this presentation. It's unfortunate we are unable to meet personally, but I am positive we will be back soon, and still it's nice to be able to share our presentations in this way. So I was asked to speak about the meaning of driving pressure during assisted ventilation, and it's a topic we've been working on over the last few years. So it's really my pleasure to be able and share with you some of our findings. My conflicts of interest are as follow, and nothing too special in regard to this presentation. So first of all, let's have a 2 minutes, 1 minute recap on what is driving pressure, generally speaking. Driving pressure is the ratio of tidal volume divided by compliance. Mathematically, this is what driving pressure is, because if I replace in the formula compliance with its formula tidal volume divided plateau minus PEEP, I get driving pressure. Why is this important? Because we are not normalizing the size of the tidal volume to the size of the patient. We are normalized the tidal volume to the size of the lung, because compliance is our best proxy for lung size. And so looking at driving pressure, we are in a way looking at what is the size of the tidal volume compared or normalized on the size of the lung. And attention to the driving pressure exploded, I would say, in the field, although someone said, well, we knew this beforehand. But anyway, the great merit of bringing our attention to driving pressure belongs to Marcelo Amato from Brazil, that in this paper published on the New England showed what was the association between driving pressure and survival in ARDS. And he indeed has shown that if you just do for let's say for the sake of time, if we just lump patients into quintiles of driving pressure here on the right, you see that these patients have all the same plateau pressure, but they get to here with very different driving pressure. So these patients start from a low PEEP and jump up to plateau pressure with a high driving pressure, and mortality here is very high. Whereas if driving pressure is low, mortality is also low. And these are retrospective analyses from randomized control studies in a totally different setting, which is prospective data collected from worldwide, just observational. We found in the LungSafe study the very same association. And there is a number of studies out there showing how driving pressure is really important to manage mechanical ventilation. The problem is that with assisted ventilation, not everything is so straightforward. Sometimes pressures are hidden, and I apologize if some of you have seen this metaphor in my slides before, but I think it really conveys well a nice idea that sometimes the pressures are hidden. We see part of the iceberg outside the water, but part of the iceberg is hidden, and it's very dangerous because we don't see it and because it can be much larger than the part we see. And out of the metaphor, it is exactly the same with pressures during assisted ventilation. We see part of the pressure on the ventilator screen, but there is a large part which is hidden and which we do not see. And this part contributes very well to the development of ventilator-induced lung injury, probably even more than the part we see on the screen. I'm sure you would be immediately concerned if you walk in a close to a patient's bed and you see a peak inspiratory pressure of 35 centimeters of water. But patients, by their own muscles, can easily generate huge negative pressure swings. And so during assisted ventilation, what is the driving pressure? This is pressure support ventilation. You clearly see the effort of the patient starting here and here, but then that gets somehow covered by the action of the ventilator. And we do not know what's going on here behind the surface of the water inside the patient. So is driving pressure in these two cases different because peak inspiratory pressure is different? Is it that simple? No, because as I say, we do not see what's going on here inside the patient. And so we reasoned that we could unveil this. Well, of course, we can use esophageal pressure, but we can even unveil the pressure which the patient is generating at it, which um, is present during the inspiration. If once the patient relaxes, we let this pressure come back to the ventilator. And so once you have your patient start the effort and you push the inspiratory hold button, the patient relaxes and you will see a pressure on your ventilator screen, which is the plateau and which depends only on the tidal volume and the compliance. It doesn't matter whether the patient pulled or the ventilator pushed. If the patient is relaxed, the plateau pressure is what we know during controlled ventilation. And so if I go back to the question I asked you before, what is the driving pressure in these two conditions? We just have to push the inspiratory hold button and wait the patient to relax. And indeed, you see that you get the very same driving pressure, no matter what, if the patient was less active or, as in this case, if the patient was more active. This effort was made in large part by the ventilator. Here, we decrease the support from the ventilator, and so the patient kicked back in to bring back the driving pressure to the same value as before. We have been validating this technique from a, let's say, physiological standpoint, showing that by this approach, the pressure you measure, the plateau pressure you measure, which is, of course, a key ingredient of driving pressure during assisted ventilation, is closely similar to that measured during assisted, during controlled ventilation, so compared to the standard. Of course, we have to obtain a patient relaxation, and not all the measurements are readable. In fact, as you see here, this is a slide I obtained from the group of Laurent Brochard, and we have a very nice collaboration with them on this topic. Sometimes you see that the pressure is not flat because the patient is recognizing that the expiratory valve is closed and is reacting to this, trying to exhale. And in this case, you will not be able to obtain a measurement of driving pressure. Still, uh, it's better not to have a measurement than have a wrong one. In our experience, this occurs in 10 to 20% of the cases, and sometimes you can repeat the hold, obtaining a better measurement. It's not just our, let's say, strange idea. More or less, while we were publishing our first paper on this topic, another paper came out with this very interesting question. Can plateau be higher than peak pressure? And the answer is yes. This is very nicely shown in this paper by Dr. Sayad. And the reason is that this pressure, this plateau pressure, includes also the amount of work that the patient was developing during inspiration, and that was hidden. Also, Claude Guérin and Dr. Metzdi applied this approach in a very different condition, which was weaning a difficult to wean patients, unveiling that this patient had a very low compliance, because once you have driving pressure, you use it exactly as during controlled ventilation. So you see here driving pressure was very high, 21 minus 5, so it's 16 centimeters of water driving pressure that allows you to calculate compliance. So going back to the meaning of driving pressure during assisted ventilation, in this landmark paper, Marcelo Amato and collaborators uh, uh, put forth as a limitation the fact that this measurement would be valid, only in passive patients. And basically, our hypothesis was that driving pressure during assisted ventilation should have the same meaning during assisted ventilation as during controlled ventilation, and so should have the same association with outcome. I'll skip this for the sake of time, but we basically reproduce the finding that driving pressure during pressure support is very representative of what's going on during controlled ventilation, and is associated with the amount of volume aerated on CT scan. And finally, the association with outcome. This slide is a little bit busy, but it shows the association between increasing levels of driving pressure and increased mortality. And as you see here, as far as driving pressure increases, mortality also increases. This relationship is not present at all for peak inspiratory pressure, because as I said to you before, peak inspiratory pressure is just looking at what the ventilator is doing, but the entire pressure that the lung sees is here, is the driving pressure. And in this multivariate analysis, driving pressure was independently associated with outcome. At the same time, we also looked at compliance, and of course, compliance and driving pressure are tightly related. And we have noticed that we have shown that for decreasing values of compliance, mortality also increases. So we are not able to tease out whether driving pressure is a marker of more severe lung, or is a mediator of lung injury. Probably both, but still, this association shows that it is an important parameter to monitor. So in conclusion, driving pressure during assisted ventilation, to me, has exactly the same meaning as during controlled ventilation. What changes is just the way we measure it. We have to obtain patient relaxation and accept that sometimes driving plateau pressure can be higher than peak inspiratory pressure. I hope more groups will join us and work on this topic, so that if with more validation, this driving pressure could become a target during assisted ventilation. Thank you very much for your attention, and please send me your questions by Twitter or email.